thank you all for coming today. What a beautiful evening and gathering today here. It's a very special day in the Jewish calendar as well, so our best wishes and for that. And I want to take a moment to applaud all the patients in the cancer world who are battling this breast cancer diagnosis on this month of breast cancer awareness. So let's see if we can give a big round of applause. And also a big round of applause to all the caregivers who are, many of them are here accompanying their loved ones as well. With that, it gives me pleasure to talk today about the breast cancer world. And what this together, both of us, what we're going to do is to paint the picture of where we were, where we are, and where we're going. And it'll give you a glimpse into the future treatments that may be coming down, as well as non-treatment interventions that could make a humongous impact in your life. So let me start off with my talk. So if you remember the world of conventional mammography to digital mammography, there has been a huge difference. So as you can see very well, the digital mammography on this side appears to be much more clear than what it used to be on a film. Then the surgery world has shown remarkable improvements, and this, of course, is the traditional mastectomy, the radical mastectomy, where everything up to the bone is removed, as opposed to the now skin and nipple sparing mastectomies with reconstruction. Women have the ability to retain the skin of the nipple and may have a wonderful cosmetic appearance. In the world of radiation, we've had tremendous changes to how the radiations are being given nowadays using very state-of-the-art image-guided techniques. Going further, in terms of left-sided breast cancers, where heart may come in the way of radiation. In order to prevent heart muscle damage, Cone Health has the technology with breath holding to prevent the damage to the heart, and that's another huge advance. So as you can see, every field we are seeing huge improvements. What about chemotherapy? And this may or may not be exactly the smile, but clearly we have made a huge improvement from what we traditionally hear about the side effects of chemotherapy. Of course, that is thankfully to all the new medications that we have for prevention. And then now I want to go into the overall outcome. If you have seen the incremental benefits of treatments for early stage breast cancer, in the world where without surgery to surgery plus endocrine therapy, and we can talk a little bit more about it, anti-HER2 therapies and so on, we've made huge progress. We've used the knowledge that we have gained by understanding the human genetics and genomics, so we can understand the genetic background of a cancer and design treatments that may be beneficial to them. And some of them may have heard these terms, oncotype. And I'm not going to go into details of any of this because that is not the purpose of the talk, but to help you understand the changes that have come about on a superficial level. HER2 is a receptor that is present on 20% of breast cancer cells, like estrogen receptor, progesterone receptor. HER2 is another receptor. And in this world, there has been even more tremendous progress. What this picture is depicting here is actually a breast cancer cell. This is a cell membrane, and there are these HER2 receptors that are floating around. There's a yellow one, a green one, a blue one. And when they get activated, they bind to each other and tell the cell to multiply. We now have medications that can bind on both sides of this receptor to prevent this from ever binding to another HER2, and therefore have tremendous treatment effects in HER2 positive kind of breast cancer, and those are the names of the drugs that are there. So incrementally, we are making a huge difference in a disease that was thought to be literally fatal because HER2 is a marker of a very aggressive cancer. Another medication which I think is worth mentioning here is where we took the HER2, anti-HER2 drug and attached to it 3 molecules of chemotherapy. And when a cell recognizes this is the HER2 receptor, binds to this Herceptin-like drug, it internalizes and delivers the chemotherapy into the cell. What an amazing improvement in the way we can deliver chemotherapy in a very effective way. Again, very superficial way of looking at this, but this is clearly another huge advance in the HER2 positive realm. Now, in the estrogen receptor positive realm, these are the patients whose cancer cells are feeding on the body's supply of estrogen, which, as you know, is a hormone as well as progesterone. So in this world, we have made also big improvements. I'm very proud to discuss this medicine, palbociclib, which has literally doubled the survival for stage 4 breast cancer in the world of ER positive breast cancer. So a little bit about how this drug works, even though this is a little complex, bear with me, it's very unique. So if a cell, this is a normal breast cancer cell, wherein all these pink guys are the estrogen receptors. When there is, in the nucleus, there is activation that goes on, which then helps activate further the estrogen receptors, which then bind to the circulating estrogen that is internalized and makes the cell to grow, multiply, and so on. Whereas when we give this pill, this internal process is completely knocked out. So therefore, the pink guys, the estrogen receptors, have become dull and basically are no longer functional. And therefore, even though there is estrogen, it doesn't have the ability to bind to the receptors, and therefore the cell will die. So this is it's a huge advance in the estrogen positive realm. We are happy to report that we now have an active clinical trial investigating this same medication in the stages 2 and 3 breast cancers. And we are happy to be one of the only centers in this area to be able to offer that. In fact, some of you may have read the news article recently about one of our patients who went on this trial and who's doing quite well. So we are trying to improve the great results that are already there with the current therapies. A word about immunotherapy. You may have been hearing this buzzword in many cancers, and in breast cancer world, we are also exploring this as a potential treatment option. Now, there is a trial that we are planning to open in conjunction with UNC, and that should help patients who have triple negative breast cancer beat this. And I will not go into too much detail into this very beautiful cartoon, but it is essentially what we're trying to do is to harness our own body's immunity to fight our cancer, which is remarkable in itself. This has been proven in many cancers, and breast cancer is also going to be one of those which we will investigate this further. Lastly, I would like to end up with this cartoon, and I hope all of you will memorize it and there'll be a quiz at the end. But the complexity of breast cancer is what I'm trying to illustrate. It's not meant to be more than that. In fact, there are work going on in multiple cell pathways to help decrease the risk of recurrence in breast cancer, and the future is bright in terms of research and development in this field. So in terms of our pioneering advances, what is Cone Health doing, and where are we excelling? We now have many trials, clinical trials in surgery, radiation, medical oncology, and also we are beginning to use survivorship and develop that program. So where do we go from here? So I've basically described to you some of the past and present and the future direction of breast cancer care and how it is transforming the survival and decreasing the recurrence. But medicine is by itself not the solution for all issues related to breast cancer. We have multiple other non-medication approaches that can have a great impact, which my partner Gretchen is going to elaborate in more detail. But I want to start off with a case. This is a case of Rachel. She's 60 years old, and she has stage 1 breast cancer that is on the left side, and it is estrogen and progesterone receptor positive and HER2 negative. She undergoes what is considered to be lumpectomy or breast conserving surgery, and we use the technique of radioactive seed localization, which spares women the burden of not having to go through a wire localization, if some people may know what that is. But this is an advance in itself, which we do here. Genomic testing after the surgery revealed that she did not need chemotherapy because she was felt to be low risk. And she received adjuvant radiation, adjuvant meaning after surgery, radiation therapy with this breath hold technology that protected her heart. And subsequently, when she saw us, we started her on an anti-estrogen therapy with anastrozole. This is our typical patient that goes through an estrogen receptor early stage breast cancer. There are many questions that Rachel, we have to answer her. One of the questions is, what kind of surveillance will I need? And what is the standard of care? And of course, this is not meant for you to be a quiz, but essentially what she does not need is she does not need CT scans. What she primarily would need is a breast exam and an annual mammogram. So there is no role of PET scans, there is no role of CT scans, because they do not help detect early breast cancer recurrences. In fact, we base it on symptoms and breast exam and a mammogram. Now, I would like to pass on to Gretchen to take over and discuss further in terms of survivorship. And we are both from Houston at MD Anderson at one point, so I'm really proud of that. And I made sure she's happy I wore a light blue shirt, just in case she would take.
Go heels. Thank you, Melissa, for a wonderful introduction, and thank you, Dr. Gudena, for really setting the stage, I hope, for giving you a little bit more information about survivorship and what you can do to reduce your risk of the breast cancer returning. And so what we've been doing that is building our program and starting with our breast cancer patients, because you all are our biggest population of patients that we treat here at the Cancer Center. And so we thought if we can get our program up and running and it be successful, then hopefully that can create a template for other malignancies, and survivorship will be the norm for everyone. So that's ultimately our goal. So who is a survivor? Who do we consider to be a cancer survivor? I've heard lots of mixed definitions from patients over the last 8 or 9 months or so. But you became a survivor the day you were diagnosed. And when I meet newly diagnosed women, I give them that badge of survivor, because I think it's important when you go into your treatment that you have that mindset of already being a survivor. You don't have to be cancer-free to be considered a survivor, again, because you became a survivor the day you were diagnosed, and you remain one for the rest of your life. This definition really encompasses your family members, your friends, those who love you. Anybody that's impacted by cancer, by definition, is a survivor. Some patients don't associate with this word at all because they think either I had early stage disease, or I know that patients had it way worse than me, I can't possibly be a survivor. But you are. And so we're working on trying to help you own that and encourage you in that journey as long as you go. So as cancer survivors, you're not alone, although it may feel that way. This is just a kind of a busy chart, but basically just to show you how the prevalence of cancer is increasing in large part because we're doing a really, really good job of diagnosing it early and catching it with our screening tools that we have now with our better mammograms. But also in North Carolina, 7,800 women will be diagnosed this year. Doesn't seem like a lot when you look at the 15.5 million, but that's a lot of women. And that doesn't include the men who are diagnosed with breast cancer as well, which we've treated here as well. So survivorship has become an expectation for cancer centers as a part of your cancer experience and as a part of your cancer care. And that's been established over the last maybe 10 years or so. The Institute of Medicine, so kind of this big organization, decided that survivorship issues were not being addressed routinely with patients, and that there was this gap. And patients were feeling a lot more anxious at the end of treatment. They weren't getting in touch with necessary resources, and so they came up with this report to kind of address those things. And survivorship is what was birthed from that humongous document. So now it's become a standard. And so I'm so proud to be a part of building our survivorship program here at Cone because it's such an important service that we provide for our patients. And our goal is for it to be an expectation. So that every patient who walks in the door knows that once I'm diagnosed with cancer and I finish treatment, then I'll be seeing someone in survivorship. So here are the main components that we do, and I'm going to briefly kind of go through these just survivorship stuff so we can get into a little bit of the other pieces of why you're actually here and how to decrease your risk of recurrence. But we help manage your late long-term side effects of treatment. We monitor for your cancer recurrence, meaning we, as nurse practitioners, we review your mammograms, do your breast exam, monitor any necessary lab work if there needs to be any, bone health imaging, all those kinds of things. Coordinate care, which is huge. So we want to make sure your primary care doctors know what we've done to and for you over the last however long, many months you've been through treatment, and other referrals and specialists and things. And then we really want to promote your overall health and wellness and what that means now that you've completed cancer treatments and beginning your life after cancer. So what are survivors telling us? They really want to know what they can do to be healthy. They're concerned about money and insurance, and they're really worried about their caregivers. And this is universally kind of across the board, globally in the cancer world, but also here in the patients that we see at the cancer center. So these are just kind of, again, global statistics. Many of you can probably relate to a lot of these with employment challenges, getting back to work, and being able to identify resources and resources and avenues in order to help you with those. So part of our job in survivorship is to help you identify those issues and then come up with a plan on how we can address them and get you back to as close to, if not better, than you were before you were ever diagnosed with cancer. And that is physically, emotionally, psychologically, your interpersonal relationships. All of that is important in survivorship, and it's overall important to your overall health as well. So the Breast Cancer Survivorship Clinic started back in January. So this is kind of our first 9 months, and when Dr. Gudena and I were preparing for this talk, we said it's kind of like birthing a baby, which I don't have any babies, but I assume this is kind of what it would be like with as much work and preparation and things we've put into our program. But this is, and I know you have the slides, so I'm not going to read them to you, but the Survivorship Care Plan is essentially a big document that we put together that details your all of your treatment that you received for cancer. It's a document for you to keep for your own record, but then we also share that with your primary care provider and other providers that you may have. It includes your follow-up plan, so how the surveillance, like Dr. Gudena mentioned, how often we want to see you, what testing needs to be done, and promoting overall health. We ask you a series of questions on a quick little survey about what symptoms are bothering you the most, and this just helps us understand better how we can help you in the future. So there's a couple of different ways. We have an hour visit, and then we have a 30-minute visit. So we get to spend a lot more time with you than potentially you may have to be able to spend with your physicians or some of your other providers here at the Cancer Center. And that was intentional because we know that a lot of these issues that come up after treatment is finished require that time and require that extra time for you to talk about and process whatever it is that you need to talk about during that time. So to date, we've seen 103 patients in survivorship. All of them have been breast cancer patients. We've given out 168 survivorship care plans. 99 of those patients have completed those surveys, and I'm just going to kind of briefly go through that. And 85% of those were diagnosed in the last year. So meaning relatively new diagnosis, relatively new finishing up their treatment and becoming, identifying their needs and life now after cancer. So physically, fatigue, insomnia, hormone changes, pain. If I polled you, I would wager that those are your top 4 complaints as well if you are the survivor here. And if you're the caregiver, I imagine you have heard those complaints from your loved ones. So those are the top 4 complaints that we address that are important, and physical complaints. Emotionally, this becomes a little bit more tricky, as Dr. Gudena mentioned. Physically, we can give you medicines to help combat a lot of these concerns that come up. The emotional and social concerns can't be dismissed. And so this helps us identify, again, the most common concerns. 57% of the patients that we've seen report fear of cancer coming back as number 1, if not number 2, concern. Now, this fear kind of is on various ends of the spectrum. For some, that fear is extremely debilitating. For others, the fear is, yeah, it's in my mind and it's nagging and I think about it, but it's not terribly concerning. So I would wager that many of you fall somewhere on that spectrum as well. And we'll talk a little bit more about that and what you can do to try to help manage that fear. Financial concerns are huge. This data actually helped us launch a deep dive into how we can help you financially, because there are a lot of resources available to patients during treatment, not as many after. And what we know is that cancer is an extremely expensive disease to treat, not only even with insurance. And so we know that often for many different reasons, financial issues become a big concern. Anxiety, depression, and then changes in your body's self-esteem, even in the midst of our changes and how much better our breast surgery has become and radiation has become. Still reporting those changes in body and self-esteem. This is our team. So as you can see, this huge long list of people who are a part of our survivorship team. We work with and in conjunction with your medical oncologist, your surgeons, your radiation oncologists. And these are just some of the referrals and things that we discuss with you and can refer for you in survivorship as the issues come up. And you probably recognize most of the people in that picture there, and they're all an integral part of your team in treatment and afterwards. So after patients finished meeting with us, we had them fill out a quick little survey just saying, how did you feel about your visit? And the vast majority of patients feel better after coming in to meet with us in survivorship, better able to understand their illness and cope with life, make themselves healthy, confident about their health, and able to help themselves, i.e. feel more empowered. Our goal is, rather than focusing on the negative impacts of treatment and how that can affect you in survivorship, focusing on how we can empower you and empower you with knowledge in your journey now after treatment. So this is a quote that I would, again, wager many of you have uttered. I'm finished with breast cancer, now what? That's the question I get so often in clinic. Now what? I'm done, now what? So how do we reduce that risk? How many of you have heard or researched some cancer myths? Anybody brave enough to share one? So these are just a couple that I hear, that Dr. Gudena has heard, and other providers here that we really want to help debunk for you and answer questions about cancer itself, what causes cancer, what doesn't. So the myth, cancer is contagious. No. Actually, we want you to hug and love on your family members whenever they're diagnosed with cancer. That actually will have a better impact on them in their overall health and wellness. But cancer cannot be spread from person to person. There's some viruses that, if contracted, can increase your risk of a cancer, something like a hepatitis C and that kind of thing. But in general, cancer itself is not a disease spread from person to person. When you have your cancer surgery or a biopsy, that causes cancer to spread in the body. Has anybody thought that? Brave enough to raise a hand? Yeah, so back in the day that could have been a concern, but our techniques now are so much better, and the way that, and the specialized tools and instruments that are used to perform a biopsy and then perform your breast surgeries drastically minimize that risk. Cell phones and power lines cause cancer. Who's heard that? So there's really no scientific studies that support that. There used to be, I know back in the 80s and the early 90s, they said that cell phones caused brain tumors, but that was also when our cell phones were, the humongous ones that we'd, looking like our iPads now. But there's really no scientific evidence to support that cell phones or power lines cause cancer. They emit a very low frequency of energy, and it takes a much higher frequency of energy to damage cells, which then can cause cancer. Okay. Deodorants or antiperspirants cause breast cancer. Did any of you change which antiperspirant or deodorant you used after your diagnosis? Yeah, lots of women do, because there is a lot of mixed messages out in the media about deodorants and antiperspirants causing cancer. There's not a lot of scientific or evidence and research to show that link. We know that some of the aluminum-containing products can affect chemical structure, but it doesn't alter it enough to show a causal relationship between an aluminum-containing antiperspirant and a breast cancer and changes in breast tissue. So maybe when you were going through treatment, you avoided all sugar, because cancer lives in sugar and it can only grow in sugar. Anybody heard that? Yeah. So that's actually probably one of the biggest myths that we spend a lot of time in clinic talking about. Every cell in our body needs sugar, needs glucose in order to function. That's our fuel. So there's no data to really support that you limiting the amount of sugar that you consume will make your cancer worse. There is a causal relationship with eating a high sugar diet that can lead to obesity and then increase your risk of other cancers, certain types of cancers, including breast cancer. But directly eating a Kit Kat bar and it worsening your cancer, there's no causal relationship there. And that's largely because of the way our body is made up, that it needs sugar in order to function. Artificial sweeteners, like having your Diet Cokes or your Splendas, they cause cancer. Heard that one? So there's very little scientific evidence, I haven't been able to find any that supports that they actually cause cancer. Artificial sweeteners like the Equal and Splenda were in the news a lot in the last 10 or 15 years or so. But they're regulated by the FDA, meaning they're regulated for their safety for human consumption. And when the FDA passed them, they give you a minuscule amount of what would actually be safe to consume. It would take a ginormous amount, does that make sense, in order to cause any damage. So largely because it's regulated by the FDA for safety, and there's no causal link between artificial sweeteners and cancer. This is a new hot topic one that I've been hearing a lot recently in the last couple of years. If I stop eating acidic foods, or I drink sodium bicarbonate or alkaline water, or I take sodium bicarbonate tablets even, and make an alkaline environment in my body, meaning non-acidic, then that'll either help my cancer go away or prevent cancer from coming back. Who's heard that? So Dr. Oz is famous for this one, and I'm not going to get started on him. That's a whole nother talk for a whole nother day. But our body is designed to manage an acid-base balance. And so the things that we consume, while it can create an acidic environment in urine, for example, that doesn't necessarily show the overall picture of how balanced your acid base is in your entire body. Does that make sense? So drinking alkaline water, while not harmful necessarily, probably in large amounts would be, probably not offering you a lot of anti-cancer benefit, and it's really expensive. Just your good old traditional water is going to be good enough for you as far as anti-cancer properties go. Questions on that? I know that's a lot. Okay, jot them down. Okay. So what can you do? Like, I've just named all this stuff that does nothing, right? You hear everything in the news. What am I supposed to do? And this is really boring and not a news flash at all. Eat your vegetables, eat your fruits, limit your red processed meats, eat plenty of lean protein. Y'all thought I was going to give you some like really cool new thing that you'd be able to go home and do to prevent. I wish I had it. I'd be a gazillionaire. Dr. Gudena and I would be on a trip somewhere. Unfortunately, the best data that we have is supporting an overall healthy diet. This is one of my favorite handouts that we give out to patients in clinic. And it just kind of illustrates the foods that are very rich in color and their anti-cancer properties. And so when I talk to patients about, when they ask me about diet and ask me about what can I eat or drink to reduce my risk of my cancer coming back, we go through this handout because it's important to know which foods to pick out at the grocery store, but to also eat them in a well-balanced way and understand what they're doing for you long-term for your health, but potentially for anti-cancer properties. And then maintain a healthy weight. So we're going to talk a little bit about exercise too in a minute. So vitamin, herbs, and supplements. Oh my. So turmeric and curcumin have been, there's actually some promising data coming out with that now. When I spent some time at MD Anderson, they have a whole department for alternative and complementary medicine. And they're doing quite a bit of research with turmeric now and beginning to start to test that in the preclinical means in the test tube. And so after preclinical trials, then they start testing them in humans. So they're starting to work on that now. As of right this minute, there's no research evidence to support it. But if you enjoy turmeric and you like, those Asian dishes, getting it by mouth, meaning by your diet rather than taking a capsule, is generally better. Herbal medicines, and when you walk in any CVS or Walgreens, there's aisles and aisles and aisles and aisles of them. I can't tell you that they offer you benefit, and I can't tell you that they're going to, that they may or may not harm you. Those herbal supplements are not regulated by the FDA, which is kind of our go-to in medicine to know if medicines or things that we take are safe. Vitamins and those kinds of things are regulated by an independent group, and generally those are safe. But a lot of these other herbal medicines, we don't know how much is actually in the capsule that you're taking. It could be a humongous amount, it could be a very small amount. So we never know exactly how much you're taking. And so that's difficult for us to be able to put a stamp of approval saying, yes, this is safe for you to take, because we don't have that information or that scientific data to back it up. So generally best to get those things from your diet and from food whenever you can. Vitamin D, there's been some inconsistent data that vitamin D may or may not support the prevention of cancer or decrease your risk of coming back. Overall, your bone health as a breast cancer survivor is extremely important. So taking a vitamin D supplement with calcium, particularly those of you who are taking those aromatase inhibitors, like the anastrozole or letrozole, that's critical. So you're kind of getting a twofer. If you take your anti-estrogen medicines, we know that those prevent your risk of recurrence. Your vitamin D may or may not offer you some benefit. There's some inconsistent data. but that's helping support your bone health, which is critical. Exercise is really, really important to reduce your risk of breast cancer returning. It also helps with treatment-induced fatigue. So for those of you that are still in treatment, while it's important for you to rest, it's also important for you to exercise. The most important thing to do for treatment-related tiredness is to move. And that I always tell my patients that seems counterintuitive. I'm tired, I would need to take a nap. But actually, if you get up and move, your fatigue will be much less pronounced. It helps reduce your risk of lymphedema, so the swelling in your arms, if they removed lymph nodes from your armpit at the time of surgery. It also reduces anxiety and depression and improves your overall health, as we know, and your overall well-being, quality of life. So there's tons of data to support that we need to exercise. I tell patients all the time, I preach it, do as I say, not as I do. I'm not great at it either, but the more that we can do every day to increase our stamina, flexibility, our overall heart health is going to not only improve your overall health, but improve your risk of breast cancer not coming back. So I can't give you that exact number. Of those 60 studies, about 20 to 80% risk reduction, which for me, that 20% is better than zero. And if you get that 80% risk reduction, then that's amazing. So I would argue that being physically active is going to offer you more benefit than potential harm. And keeping a normal weight, BMI I know is relative, but that's the standard we have. Keeping a low BMI reduces your risk of breast cancer coming back. Women who are more active reduces your risk of breast cancer coming back, or in those of you who haven't had a history of breast cancer, you ever getting breast cancer. So the Livestrong program, does anybody know about the Livestrong program at the YMCA? Has anybody participated in it? Awesome. So I think every patient should have to go through Livestrong whenever they finish treatment. I can't say enough good things about this program. It's free. It's a free 3-month membership to the YMCA and for cancer survivors, and you're significant. So if you want to take, whoever you want to take, your boyfriend, whoever. And what they do is design a program for you, understanding the limitations that you may have as a cancer survivor based on your surgery and your treatment. You're in a community, in a group kind of setting with other survivors, and they help you develop a fitness plan and get you more confident and comfortable in being in that gym setting and being more physically active. My favorite story I like to tell is I sent an 84-year-old lady there maybe 2 or 3 months ago, and she walks with a cane, and she said, "Gretchen, I want to do this because it's important for me. I know I may not ever get rid of my cane, but it's important for me to feel as independent and as comfortable at home as I possibly can and get a little bit stronger for whatever time I have here left." And so she went and loved it, had a ball, made friends with everybody there. So it's a great sense of community for you too. Have I sold you on it? Okay, all right. There's 2 locations in Greensboro. I know that the Reedsville location is potentially going to open up as a site. There's one in High Point as well. So lots of areas. This is kind of the general area of patients that we treat. So there's no excuses, is what I'm telling you. What I've told patients that live a little bit further out and some that live in Virginia, I give them the brochure and say, take it to your local YMCA. And oftentimes they'll have a program or can be in contact with somebody about how they can initiate their program in your area. So I'm so grateful to be finished with treatment and have cancer behind me. Why am I not back to normal? I feel like I'm going crazy. Y'all said that? Some of y'all have said it to me, so don't lie. Okay. So talking a little bit about risk of recurrence and then we'll wrap up talking a little bit about fear. So I wanted to do another case, and then this is interactive, so you're gonna have to talk to me, okay? So Susan's 34 years old. She was recently diagnosed with a large, so greater than 2 centimeters, invasive breast cancer in her right breast. The estrogen was estrogen, so her hormones, her breast cancer hormones, estrogen receptor were negative, her female hormones, and her HER2 receptor was negative as well. She underwent lumpectomy, and she had one lymph node removed from her armpit that was positive at the time of surgery. Her surgical margins were positive, meaning there was a little bit of cancer left behind. After surgery, she got chemotherapy, and then radiation was recommended for her, but she decided not to do that. So what do you think are the most important things about Susan's case to consider if you were Dr. Gudena or myself and you were telling her about her risk of cancer coming back? What do you think? She didn't get radiation. Awesome. Positive margins. Having a lymph node positive. Triple negative. Are y'all cheating? What else? Does her age have anything to do with it? Yeah. She's young. She's younger than 40. Large tumor size. Awesome. I think y'all hit all of them. So in general, these are the largest factors that increase your risk of recurrence. So in talking with Dr. Gudena, I asked him, what kind of percentage would you give this patient and her cancer risk for coming back? He said probably about 50%. Now, if she went on to get radiation, if we were able to clear her surgical margins, if she did all the rest of the things that we recommended, then her risk would drastically reduce. Okay? So because of her case is very high risk, there are some things that we can help with and other things that are out of our control. Triple negative cancers in general recur a little bit earlier, so within the first couple of years after diagnosis. And then inflammatory breast cancers, which in general are relatively rare, but when they happen, they have a higher risk of the cancer coming back. Everybody with me so far? Okay. So fear. We talked a little bit about this. I've told you that over half of my patients that see us in clinic tell us that this is something that really, really worries them. It's constantly on your mind. Transitioning from being a patient to being a survivor is largely impossible for some patients. And they find that dealing with that fear is all-encompassing. They can't think about anything else. They can't function and think or do. They can't be a mom. They can't be an effective worker. They can't do anything except worry about this fear. Living and coping with uncertainty becomes impossible. What a lot of the data shows is that her actual risk of cancer coming back has nothing to do with her perceived risk. So what she thinks in her mind of her perceived risk of the cancer coming back. So Dr. Gudena and I could tell you, you had a very early stage breast cancer. We treated it with our most modern therapies. You have a very low risk of that cancer coming back. But to you, that risk is 95 to 100% chance it's going to come back, right? That's fear of recurrence, okay? That doesn't match up with what we've told you is that your actual risk of things coming back. So what do we do about it? We know it's a big problem. Sadly, there's not a lot of research in this area. Part of my responsibilities when I was at MD Anderson was to do a big comprehensive literature search. And basically that's just big fancy for spending lots of time in the library, going through hundreds and thousands of articles on this very topic. I was able to find 7 research articles. The largest majority of them were on practicing mindfulness to help improve how your mind and your body function with that fear. Seeking professional counseling or therapy, which we have here at the Cancer Center, and I'll talk to you about. One of the more interesting articles was how you can learn how to better communicate those worries and your concerns with your cancer providers, so with your doctor or with your nurse practitioner. This particular study, an oncology nurse practitioner coached patients in the questions that they should ask and what they should think about when they go back to see their oncologist. And what they found was that during that coaching, they were able to put the patient, number one, at ease that their questions and their concerns were going to be addressed during that next visit, but also it drastically reduced their anxiety and their worry, regardless of what the doctor said, because they felt like their voice was being heard and they felt like their concerns were being answered and addressed. So, did we do anything in this area to actually treat the cancer or any potential cancer there? No. We're dealing with your mind and changing your mindset and how you think about cancer and how you think about fear and living with uncertainty. We have lots of really amazing programs here that I'm so proud of. Finn, many of you may have already gone through Finn, so finding your new normal seems like an impossible task if you're right out from treatment. What is a new normal? What does that mean? What is it supposed to look like? Why doesn't my normal look like her normal? This program gives you the tools to be able to navigate that a little bit better with a group of like-minded survivors. They're all not breast cancer survivors, but they're all cancer survivors. And it's facilitated by a professional counselor. And you use that time to discuss important survivorship concerns by experts. Okay, so it's a 2-hour class. It meets on Monday evenings. It's an 8-week program. This is another one of those things like Live Strong I think everybody needs to go to. Part of my orientation here, I went through Finn myself and was an observer. And the transformation that women had during this program is phenomenal. Watching their growth over that 8-week period, and them being able to wrap their minds around this vastness of uncertainty that now the rest of your life is going to be, potentially, is huge. So this program really offers, it's free, and it offers you, hopefully, some reassurance and support with survivors here at your cancer center. We also have other amazing support groups for you that are sponsored by our Light Foundation. If you haven't attended any of these, you should. There's a lot of really powerful healing that happens at these things. If you're not a group therapy person, I get it. There are opportunities for you to have one-on-one counseling, and that's again free. Everything I'm talking about here is free. So we have a partnership with UNCG. Their counseling interns come in the fall and in the spring. They're amazing. I send many patients to them. They give them the time and attention that they need to talk through a lot of these issues and concerns that come up. And we can also refer you out in the community as well if you wanted to see a psychiatrist, for example, or a professional psychologist. But our folks here are wonderful. Yoga meditation, as we talked about, is a potential option to help deal with that fear. They're free, offered here at the Cancer Center as well. And then our breast cancer retreat, that's again sponsored by the Light Foundation. Many of you may have already heard about that and already marked your calendar for it, but I want to personally plug it for you because I think it's a day of healing for you and a time for you to process together as a group. I've sent several patients to these retreats. They occur annually. Melissa can speak to the power that these types of things have for women in their journey after cancer. So become a part. If all of those things I mentioned are not your cup of tea, that's fine. Find something that speaks to you as a cancer survivor that makes this breast cancer community of people, like-minded folks like you, seem just a little bit smaller. It seems so overwhelming to think about 7,000 new women that could be diagnosed this year. Maybe find you a buddy here tonight even. Becoming a light guide. Now that when you finish with treatment, you have the opportunity to give back and support another woman through her journey and through her cancer treatments. Volunteer here at the Cancer Center. I love seeing our patients come back and volunteer. I see some of you here, my faves. Participate in breast cancer awareness events in your community, go to charity races, come to Cancer Survivor Day in 2017, which will be amazing. Whatever it takes for you not to feel alone in this, that's really the most important thing. This is one of my favorite poems. This is actually posted on the palliative care unit at MD Anderson. And while we're not talking about palliative care, we're talking about survivorship. Cancer is so limited. I know we talk a lot about risks and statistics and things to do and not do. But cancer can't do any of these things. It can't cripple love, shatter hope, corrode faith, destroy peace, kill friendship, suppress memories, silence courage, invade the soul, steal eternal life, or conquer the spirit. It's powerful. It's not that powerful. Cancer is so limited in what it's able to do. And part of why it's such an honor and why I feel like I have the best job in the whole world is because I get to not only celebrate with you, but help you continue to learn and grow in your new life after cancer. These are pictures from our Cancer Survivor Day event with the Disney princesses that was at the Science Center. And you may recognize, some of you may have your thumbprint on that little poster there. So thank you for allowing Cone Health to be a part of your cancer journey. Thank you for allowing Survivorship to be a part of that now and being open to that. It truly is an honor to be a part of this team and of your team. What questions do you have? Yes.
I have really 3 questions that I'd like to address. One, my previous oncologist, Dr. R, said that hormonal therapy should be 10 years. And then I was following with Dr. K, and she said that she would suggest yearly visits. Mm-hmm. And third, Dr. Carey and Andrews from the UNC Lineberger Comprehensive Cancer Center noted that research is now showing that 10 years of not only tamoxifen, but also the aromatase reduced risk of recurrence. And I wanted some answers on that.
So you brought up 3 really amazing points. Do you have all 3? You got them?
I think we can answer
okay.
those.
He's got them.
Yeah, so it's really critical. I think there is a lot of debate in terms of what is the standard duration of therapy, and we cannot say one size fits all. So there are certainly patients who definitely need 10 years. There are others who may just need 5 years. So the current data is tamoxifen 10 years is better than 5. And as far as the aromatase inhibitor therapies, there is just a recent publication called MA17. This trial has shown that there is no difference in survival between 10 and 5. However, if patients had lymph node involvement, they seem to have an improvement in terms of their survival by continuing beyond 5. So as we learn more and more, now I talked a little bit about genomics. I had a little graph about it. We are realizing that these decisions we are making arbitrarily based upon a few clinical factors. Maybe you need 5, maybe you need 10. We are now learning that we can predict who may benefit from 10 and who may benefit from just 5 years by analyzing their tumor DNA. And so this is the way I approach the decision about 5 versus 10. And have a more nuanced decision as to who needs it for longer and who needs it for less. Not everybody needs it, but there are some who need it, and so we have to pick those up who really need and then continue that therapy for those. So I don't think I can give you, in your specific situation, the answer to your question, but certainly this is evolving, and there is every year new data coming out in this to answer that question.
Okay, one more question.
Oh, okay.
So how are the 5-year people to keep abreast of what's going on? What are you doing to keep us in the loop?
Yeah, so I think in terms of where we are going, it would be with your oncologist. That they are the best persons to basically advise you. Now, if you have stopped seeing a medical oncologist, periodically it is probably a good idea to touch base, even if you're not seeing annually, if you're 10 years out or whatever. So that would be the. No, I was saying that it's better to have that conversation with your oncologist as to, for my particular cancer, what is the current update. Sometimes Wall Street Journal, sometimes the news reports, all of these may initiate the discussion for a few patients who may want to come back in and have the discussion about, does this apply to me, and whether this should change our management. So I think for those reasons, it is better to have that conversation, because each individual patient is so unique and cannot be summarized as one general stroke. So I would have you discuss that. Okay.
What else? So the question was, and I'm repeating for camera, for patients who've had bilateral mastectomy, so have had both breasts removed, and then have an abnormal finding requiring a biopsy, and it shows a lobular neoplasia, which not necessarily a cancer, but needs to be removed, and then that comes back. So what would be the recommendations?
So I'm assuming that, so most people have a conception that if you have bilateral mastectomy, the risk of recurrence is 0. And unfortunately, I wish that was true, but there is still a 5% risk of recurrence, especially under the axilla, where there could be a little bit of breast tissue in spite of the mastectomy. That being said, lobular neoplasia, I'm assuming you're talking about atypical lobular hyperplasia, which is not itself a breast cancer. It is sort of an abnormality in the glandular tissue of the breast. And your question is whether we use breast cancer index?
I know that can indicate the possibility of breast cancer, which we already know, right?
Correct.
Now, if we think that it has gone back, the atypical
Lobular.
hyperplasia has gone back, and we have a biopsy on that again. And what are your thoughts on that?
Yeah, so that patient definitely has still some glandular tissue left behind, and that led to the atypical lobular hyperplasia. But I don't think there is, other than resecting it and watching it, there is nothing further that I would do for someone like that.
And that wouldn't be considered a breast cancer recurrence, meaning that wouldn't be considered the breast cancer coming back.
Is that possible that that could turn into?
Not really. So it is not a precancerous lesion. Yes, as someone here in the front. Yeah.
When I had my mastectomy done, they did not do the oncotype test because she said that because it was in my lymph nodes, that they didn't need to.
Correct.
But doesn't that test tell how well your cancer will respond to your chemo?
So the question was for patients that get mastectomy without lymph nodes,
With lymph
nodes, but did not have an oncotype test sent, so part of that genomic, getting that genetic profile back, would it be beneficial to do something like that now to give risk of whether or not chemotherapy is going to be helpful or not?
I think her question is, why wasn't it done?
Yeah, why wasn't it done at once?
So
Yeah, sorry.
Oncotype DX is a genomic test which analyzes for 21 genes in the cancer cell. These are not inherited genes, these are true cancer genes, and can predict who needs chemotherapy and who doesn't. So broadly, that's what it's meant to do. It is studied very well in lymph node negative patients, because lymph node negative, patients who have lymph node positive, they are perceived to be very high risk to begin with. So what we're trying to do with this test is we take the lower risk patients and see who we can not give chemotherapy to. So we take the lower risk, which would be the lymph node negative patients, and run this test and pick the high risk group and only offer chemotherapy to that group and not do chemo to the rest of them. When it comes to lymph node positive patients, Oncotype DX has had some data, but it is kind of very small and retrospective, meaning it is not the strong data that you could hang your hat on. And therefore, it is not considered standard of care by any of our guidelines to do Oncotype on the lymph node positive patients. But I think that is going to change, hopefully, in the future with better testings that we are looking at, because not all lymph node positive patients technically benefit from chemotherapy. Although that's how they're treated currently, that may change in the future with some new data coming up with new molecular testing. So your oncologist was, doing the appropriate management for the node.
I'm getting a little confused because it tells whether or not your recurrence is likely, but as far as how your cancer responds to the treatment, aren't they two different things?
It is two different things. So it tells you two things. One is a prognosis. It tells you whether your cancer has low risk or intermediate risk or high risk. On the second, it predicts whether chemotherapy would work or not.
And it wouldn't do that for someone that had it in their lymph nodes?
This test has not yet been studied in an appropriate fashion. In fact, that study has been done. We don't have data yet.
You're asking questions ahead of your time.
Yes,
It's my understanding that Oncotype DX test is only for estrogen positive.
exactly, correct.
So if you're triple negative, does the test, I have the test done even though I'm triple negative, does that mean the information is invalid?
So triple negative patients, the Oncotype test is going to universally, for the most part, suggest high risk. It does have those genes involved in estrogen progesterone as part of this test panel. The test itself is highly skewed. So if you're estrogen progesterone negative, it is going to automatically show high risk. So it is not indicated to be tested for the triple negative group at all. Please.
Just a simple question. I've heard that if you're double positive, that you should not eat soy. Is that any truth to that?
Another one of those that I personally would not tell patients to avoid soy, because plant estrogens, which is what you're referring to in soy, are universal. Every fruit, vegetable you eat has some component of plant estrogen. Soy, what I suggest patients, and this is not based on data in full, for clarification, there's really no data to support one way or the other. What I always tell is don't take supplements containing soy. If you are going to eat edamame, go have it. If you're going to have your sushi, have soy sauce. That's perfectly fine. Yes.
I was told some time ago that when it comes to soy, I was told that soy was a weed. That's how it originally started. Much like canola, the rapeseed. And if somehow genetically altered all this stuff to where it's not as detrimental to your health as it would be in its raw form. Rapeseed, which is what canola oil is made of, the raw plant in and of itself is so toxic that bugs won't even eat it. And it can be deadly. It can cause kidney failure and a whole bunch of other stuff based on what I've read. But they managed to take the plant and over generations of genetic altering, they've been able to, I guess, for lack of a better choice of words, breed out that type of stuff in the plant to where it's supposed to be pretty good.
I would not know.
One thing that amazes me is that, I didn't really know until me and my wife, especially her, went through all this stuff, that there are so many different types of cancer that requires its own particular therapy. What will work for one cancer and a therapy will not work on another type of cancer.
Right.
And that's true of breast cancer as well. Yeah,
Right.
not that's true just in your population.
Yeah.
What may work for one may not work for another.
The overwhelming caveat to all of this discussion about myths and all of this is that there is always some common sense. If the cell phones are not causing brain cancer, don't put it under your pillow and sleep on it. I think but I'm just suggesting that yes, certainly there is no data, but that doesn't mean there is data to support it or against it. So all we're trying to do here is to at least start having those discussions when you believe something. Is that really true? So anyway,
Yeah.
any other thoughts?
A glass of wine at night. It seems like they say.
I love it.
She needs a bottle.
So the advice that I tell patients is that, moderation is important. So if a glass of wine brings you enjoyment, I think that that is completely reasonable and fine. Should you go out on benders like you were, 21 years old in college? No. But should any of us be doing that? No. So, I mean, really, the glass of wine or the occasional alcoholic beer, liquor drink, whatever, those things are in moderation, generally okay.
I completely agree. On chemo, no, probably.
On chemo, no. Yeah, don't do that. But
there are beliefs that we all have, right? I mean, people strongly believe certain things, and whether it is organic foods, whether it is any of these different things, and if you believe it strongly, then more you should consider that and doing that. What I bring to some of the patients bring to my office are a bottle without label, sometimes with some pills that we don't know what they are, that were given by a Chinese herbal store. And when they ask me whether can I take this, and obviously, there's no way I can tell, yes, you should take it, you shouldn't take it, we don't know what it would do to you. Or they might suggest name of a mushroom. Recently I heard about a pig's tail mushroom. I don't know what that is. Certainly, I would not know how to answer those questions. So, see if the source is reliable. Is all I'm trying to say. If it's your body, what you put in is going to have an effect on it. So make sure the right source, the right person, the right information, and before you consume something, in the hope that you are doing something more by yourself to preventing recurrence of breast cancer. So that's my only take on that. All right.
Anybody else?
Sounds like.
Thank you so much.
Thank you all.
Thank you.